We are on episode 6, Lithium Interactions. Today we'll be talking about the toxic trio. Lithium does not play well with others. Put it with the wrong partner and it's like a bad relationship. The most dangerous partners that you should be looking out for are your NSAIDs, your ACE inhibitors, and thiazide diuretics. Together, they are what we'll call the toxic trio. And for both the exam and real-life practice, you must know not just that they are dangerous, but exactly why they are dangerous. Here's the foundation. Lithium is 100% renally excreted, and it competes with sodium in the kidneys. That means anything that reduces kidney clearance or changes how the body handles sodium can cause lithium levels to spike. So when a patient on lithium suddenly becomes toxic, it's almost never random. There's always a reason hiding in the med list or in that patient's hydration status. A patient who's on lithium and is also taking NSAIDs, it's like a trap. NSAIDs are very sneaky. They block prostaglandins, and those prostaglandins normally keep renal arteries open so blood can flow freely. So when there's no prostaglandins, we're going to have less renal blood flow, which is equal to lower GFR, and of course, less lithium will be cleared out of the system. So the result is that lithium levels would rise, and sometimes it can rise pretty fast. For your exams, it's important to note that even over-the-counter ibuprofen can push a stable patient into toxicity. So if you see patients started ibuprofen, now has tremors or nausea, the answer is NSAID-induced lithium toxicity. Let's look at the ACE inhibitors. Look at the ACE inhibitors or your ARBs as very creepy, or they are creepers. They lower angiotensin II, which means that the vessel leaving the glomerulus doesn't constrict as much. It sounds fine, right? But here's the catch. It drops blood pressure, and when that blood pressure drops, it reduces GFR. And of course, when GFR is reduced, we have less filtration. And of course, less filtration will lead to less lithium excretion. Unlike NSAIDs, ACE inhibitors raise levels slowly over days or even weeks. For your exams, you want to pay attention to classic questions. For example, an elderly patient who is hypertensive switched to lisinopril while on lithium develops confusion and tremors. That's ACE inhibitor-induced lithium toxicity. Thiazide diuretics, I call this one the sodium thieves. And this is serious. Now, this one is the exam's favorite. Thiazide diuretics increase sodium excretion in the distal tube. So when the body senses that sodium loss, it tries to reabsorb sodium in the proximal tube, and lithium goes right along for the ride. So in your exam, if you see questions with lithium and that individual is on hydrochlorothiazide, assume the question is about toxicity, even if the patient's dose has not changed. Let's look at some other sneaky interactions that are not so common, but you never know how your exam questions are going to be. So loop diuretics, not as strong as thiazide, but they are still risky. Your flagyl, metronidazole, it can also raise lithium. The mechanism is unclear. Low salt diet mimics whatever thiazide is going to do when it's associated with lithium. So sodium reabsorption increases and lithium will rise. How about caffeine? Caffeine increases lithium clearance, so inconsistent intake will fluctuate levels. SSRIs and lithium are a rare combo risk. Watch for serotonin syndrome, especially confusion, hyperreflexia, and fever. So the rule is always review the full med list before blaming the lithium dose. So this is how it looks in practice. We're talking about clinical consequences. Or it might appear the same way on your exam. So the patient has been stable for years, then suddenly develops GI upset, confusion, tremors, or ataxia. You check the history And there it is, a new med has been added recently. So for your exam, if the stem says recently started ibuprofen, ACE inhibitors, or thiazide diuretics, the answer is lithium toxicity from drug interaction every single time. So let's look at a case, clinical scenario. A 58-year-old man on lithium for bipolar disorder is switched from amlodipine to lisinopril for hypertension. 2 weeks later, he presents with confusion, slurred speech, and coarse tremors. Lithium level is 2.1. So what is the cause? ACE inhibitor reduce GFR. So this tells me that lithium is not being cleared, which increases lithium level in the blood. So what would be your next step? You want to stop lithium, hydrate the patient, and hospitalize if needed. Let's look at another scenario. 45-year-old woman stable on lithium for 2 years, develops knee pain and starts taking ibuprofen every day. Within a week, she reports nausea and diarrhea, and you check lithium level is 2.4. So what would be the cause here? We're looking at NSAID-induced clearance. So how do you manage this? We want to stop both lithium and NSAIDs. You want to hydrate and monitor that patient closely. These cases are exactly how God tests your ability to connect dots, not just to memorize numbers. So let's do a quick reminder, baseline monitoring. Before starting anybody on lithium, you want to make sure you check BUN and creatinine levels. We also want to check TSH, know their electrolyte status. You want to check pregnancy tests, your HCG, you know why, and also think about an ECG if it's indicated. After adding any new medication, you always want to recheck lithium levels. One of the exam traps are a patient can have a normal lithium level and still be toxic, especially in the elderly or those with renal impairment or drug interactions. So the toxic trio, NSAIDs, ACE/ARBs, and thiazides, are lithium's worst enemies. They either reduce kidney clearance or mess with sodium handling. Add dehydration, low sodium, or kidney disease, and you've got a classic exam scenario. For the test, remember, new medication plus lithium is equal to check for interaction. And in real life, it's the same. Protect your patient by always asking, did you start anything new? So in our next episode, we'll shift gears from lithium to another powerhouse, valproate, and compare how its monitoring, side effects, and drug interactions differ. Hit subscribe and stay tuned, because every episode moves you closer to mastering psychopharmacology the smart way.